All right, morning, everybody. We're going to get started here. One, I want to welcome everyone to Michigan, and especially our out-of-town folks. I really appreciate you guys coming and bringing this uh, session to reality. This is the first time our department is running a workshop before our annual visiting professorship, and we hope you all get a lot out of it. I want to also thank our sponsors. We have a list of sponsors, and actually our gold sponsor, LinkDX, is outside, and without their support, we wouldn't be able to continue to bring these educational events as well as we can today. As everybody knows, I've been interested in HoLEP for quite a while, not as long as many of you here. Here are my disclosures, no conflicts of interest. I'm going to begin with a picture of this paper that Peter will remember from a long time ago, 2019 with 2024, okay? HoLEP is a gold standard. For any of us who have done HoLEP, for sure, we agree that HoLEP should be a gold standard procedure, but is it really? And if you look at it in terms of the dissemination, and you will see that HoLEP, which is the green bar at the top, the numbers look somewhere between 4 and 6%. This is Medicare data in the US between 2012 2021. The big red area is TERP. The purple area is vaporization. And there's a low bar with TUIP and a low bar with suprapubic prostatectomy. But HoLEP is there, but not making a huge amount of leeway. And there's this idea of dissemination of technologies, a concept that I've been reading a lot about. And those of you who have read Malcolm Gladwell's book, Tipping Point, may be familiar with this. And the idea is for new technology really take off, you have to get past the tipping point, right? And we haven't done that. And one of my sort of passions is to figure out how we can get past this tipping point for HoLEP. Right? We're all interested. We all want to do it. And one of the approaches that I've taken is make this the gold standard, actual real gold standard for BPH surgery here at the University of Michigan. So by bringing all of you here together, help us to learn about it, is one of the milestones that I have set up for our program here. So again, I appreciate you guys coming for this. If you think about the diffusion, there's this chasm that they call for new technology diffusion, and really the technology has to be getting past like 18% to hit the inflection point and take off. And as you saw in the previous slide, we're like at 4 to 6%, and we really have a pretty far way to go. You know, we have made some progress. Lori was telling me before she used to know everybody by name. And now there are enough people that she doesn't know everyone by name, and you'll meet a few more here today. But we still have a far way to go before we really get past that chasm. The objective for today's learning, therefore, is to, as stated here, enhance medical professional understanding of the evolution, techniques, and practical applications of HoLEP. We're going to cover everything from the story behind the HoLEP, history, anatomy, the classic technique, and all the variations on the themes as well as outcomes and complications. For housekeeping, we do have some breaks built in, but feel free to use the restroom, go out, refresh your coffee or get some water. Lunch is provided. This meeting will end probably around 4:30, something like that, and then grand rounds will follow in here. There'll be some time after our meeting before grand rounds when they have to reconfigure the room. So they asked us to go hang out outside by the bar area, okay? And then for all the speakers, except for Peter, who has to go out with our residents, all the other speakers, we've arranged for us to have a private dinner here after the meeting. And of course, here are our speakers. Most of you know each other, many in the circuit for giving talks for HoLEPs and training other people. We have a full schedule. So I'm just going to kick it off with our first speaker, who really needs no introduction. And Peter, there will be a formal presentation, introduction by Ganesh at Grand Rounds today, so I'm going to do a very brief one. Since most people here know you. Peter is currently professor of surgery, University of Auckland. He is clinical campus dean. He is head of the Bay of Plenty Clinical Campus. He has done many things. He's part of almost every international professional society. He has won numerous awards. He's got distinguished career awards from SIU. He's done things that many of us in academics would just be envious of. And of course, relevant for today, what Peter has done is he's man number one. He's the key innovator for HoLEP. And everything that we talk about today would not have happened without Peter's insight and intuition. And everything we talk about is really a derivation of work that he has done. So without any more delay, I'm going to ask Peter to come up. I told Peter it is a informal talk, and we want to really learn about his thoughts, his thinkings, and the story behind why he came up with HoLEP and how has it gone from his perspective. So come on up, Peter.
Yeah, thank you, John. Very generous introduction, and it's a thrill for me to be the 38th Reed Nesbit Urologic and Visiting Professor. And looking back at the galaxy of stars who have gone before, they're all cancer guys. I couldn't really say that there was a BPH guy amongst them, so you really are breaking new ground by inviting me to your meeting. So the evolution of HoLEP, and I apologise to those of you who have already seen this, and like Joel and Nicole, for example. I know they've seen this a couple of times, this talk. Never gets old. But it's always useful just to take a look back at where we've come from. And yeah, I think that, not to get off on a tangent too soon, but I think John's concern about the tipping point, what we've always lacked is company support, because there's no real company that can claim it. There's very few ways that they can make money out of it, because HoLEP was predicated on reusable blades, reusable fibres, and you could do them incredibly cheaply. And without that, you don't have the horsepower to really push it. So it's all been organic. It's come through from surgeons themselves, and that's why it's still there, and it's still slowly expanding. And I think that's a very important aspect to it, whereas the others are more the boom and bust. We'll talk about the first procedure we'll talk about. I was with Wilson driving along, and I said to him, and of course when we came on the scene, there was VLAP. And he said, well, what's VLAP? And, and it's a fair question, because that was just the biggest thing since sliced bread. And I entered the fray, and people were queuing up outside the convention centre to get seats, and everyone wanted to hear Tony Costello talk. And now nobody's heard of it. You know, there were 8 companies selling laser fibres, for example, that all just folded. So there is a lot of boom and bust going on, and we'll hear more about the various other technologies and techniques over the time. But yeah, take you back to when we entered the fray, which was 1994. We bought our first high-powered holmium laser, and really there was only one act in town, and that was the neodymium YAG. And it was a procedure called VLAP, visual laser ablation of the prostate, and it was very popular. It was easy to do for the urologist. It was urologist friendly, but it was patient ugly, and that's really sums up the story with the procedure. It was well studied. There were 8 randomised controlled trials with long-term follow-up. They showed that at 12 months there was equivalent score reduction over and over again, and equivalent flow rate improvement. But to get to that 12-month point, the patients went through a lot of grief, much as they do with Resume and some of these other ones these days. And it was the same issues: prolonged post-op catheterisation, irritative voiding symptoms. It took a long time before they really started to thank you, because it was they were very unhappy for a start, and there was a much higher reoperation rate. So we bought a 60 and 60 dual-length machine from Coherent Medical. That was the first high-powered holmium laser they'd sold, and that was really our opportunity, making something out of the holmium. Holmium was said not to be hemostatic and of no value in the prostate, so that worked out well for us. And this was the first iteration, the first technique that we tried to do our VLAP. Now, if those of you who remember VLAP, it was basically 60 watts for 60 seconds times 4. You just basically did four burns, and then you got coagulative necrosis over the space of 3 months, and that was the procedure. Very simple. So we were hoping with the holmium we'd be able to incise and ablate a little bit of an extra channel so that we could get early catheter removal was the main thing we were concerned about. So we started out, we did 67 patients. We changed out fibres for a start. We moved from the VLAP, we did the VLAP, and then we used the in-firing fibre for 67 of them, and then they developed a low water content dual wavelength side-firing fibre, and then we used that solely for the last 43 of these. Some still had irritative symptoms. There were an acceptable rate of recatheterisation, but the cath rate was only a day or two as opposed to a week or two. And we got reasonable flow rates and symptom scores. And what we learnt from the CLAP, which obviously all urologists know intuitively, that the more tissue you remove, the better the clinical benefit. And this just reiterated that for us. It became quite clear that holmium was, in fact, hemostatic. It wasn't not as had been said previously with the lower powered holmium, and it became clear that the whole ND-YAG component was unnecessary. So and was responsible for the poor clinical results. So we abandoned neodymium and moved on with ablation using that side-firing fibre initially. We called that procedure HoLEP. It's still alive and well, and that's the route that the company was hoping we would go down, but we were a great disappointment to them because we were constantly looking for more efficient ways of getting rid of tissue. And we all know, everybody in this room has come across ablation probably at some level, at some time, and they're all the same, whether it's electrocautery or whether it's laser. You're hard-pressed to choose between, you see two parallel screens and pick which one's holmium, pick which one's green light. They all look pretty much the same in terms of the procedure and the technique. And neodymium back then, you could use a free beam at 100 watts or more, and it was quite a scary proposition, but you could definitely blow a big hole in the prostate. There was no question about that. And then the contact tip, sapphire tip fibres allowed us to use neodymium like a hot poker, and so people made channels in that way. We contributed our two different techniques. KTP came along later and then turned into green light, and then more recently thulium, a brace of different diode wavelengths, and of course the LBO green light. But it was 14 then, it's way more than 14 now, but they all do approximately the same thing. But this was our experience with HoLEP. It was the 74 patients, and this is early follow-up. Acceptable recatheterisation rate, reoperation rates, and irrigation rates, and not too many patients requiring analgesia for dysuria. And we studied them again at 7 years, and it was durable. And it was, once again, if you make a decent channel, usually it survives, and you get reasonable results in the longer term. And you can see the reoperations were mainly for other things. But the lessons, once again, from the HoLEP phase was that there were less irritative symptoms and a good acute clinical effect. But it, like all of these procedures, slow, tedious and aesthetically very unpleasant. And the worst crime of the lot, inefficient. So we moved away from that side-fire fibre by sawing pieces off and moved back to the end-fire fibre, and started doing full-time resection. And this was just basically carving the prostate in a systematic way into small pieces that weighed less than a gram. Any bigger than a gram and you were in trouble because we had no way of getting the tissue out. And so this was 1996, and published that in the Gold Journal, and later in the Endourology Journal, a comparison of our three phases. Holmium resection obviously did best. Resection, just like TURP, gets pretty reasonable flow rates, and that's what we come to expect from an ablative technique. And so then we started doing trials to establish holmium resection's place, because neodymium was still around, the VLAP was still a procedure, and we did a randomised controlled trial which looked at the two techniques, and we found what we knew we were going to find: a big difference in the catheter time, significantly more dysuria in the VLAP group. We did urodynamics pressure flow studies on all of them, and the pressure relief of obstruction was way better in the holmium resection group, as was the reoperation rate. So we felt, apart from a shorter operative time with VLAP, that holmium resection was far superior, and this was one of the final nails in the VLAP coffin. Along with this, in parallel, Olympus started creating some equipment that they're the ones on the left, and the one on the right that is the Stort's device, and other urologists developed some bespoke tools as well, and this was very important in parallel. And we also used the holmium resection technique to do the FDA study. The FDA study, they got 510K approval, and this also applies to HoLEP as well. So this was essentially the pivotal trial for HoLEP, because the FDA didn't mind whether you're nucleated, incised, or resected with holmium. It was all the same to them, so that's fine. So holmium enucleation, of course, is FDA approved. And these were urodynamically obstructed patients, and they were compared to a standard monopolar TURP. Less perioperative morbidity with holmium, but equivalent in all other areas: continence, potency, symptoms, and when we repeated the urodynamics, they were both very similar in terms of relief of obstruction. We followed that group out to 4 years as well, and basically showed that both techniques were reliable and durable. So definitely more efficient than ablation, but relatively slow and inefficient still, slower than TURP. So that was obviously still a problem. And once you got above 2 grams, you could be there for a long time trying to sort out the fragments. And so when we started to develop these morcellators and also develop the surgical planes, such that we were resecting, we were enucleating back to the bladder neck, and then at the bladder neck, sometimes getting out the resectoscope and just carving up the fragment, other times just carving it up with the with the laser fibre itself. But we were really looking for a mechanical morcellator, and convinced the Coherent engineers to help develop one, and we also started to develop one with a local firm as well, which plugged into the compressed air. That's the bottom left one, but that was really quite jerky, and it didn't really hold the pieces very well. The one we started with and did the original publications on was just an arthroscopic shaver, just standard orthopaedic kit, and we placed that suprapubically through an Adacath device, Adacath channel. A lot of mess, a lot of fluid flowing everywhere, but it was ruthlessly efficient and very scary. Yeah, so we decided that transurethral morcellation was the way forward, and that was the original handpiece. They were 3mm blades, so they were way too slow for a start, but then we developed with the Coherent engineers the 5mm blades and different sized apertures, and some slanting and some straight. Tried various things, and it was an off-the-shelf roller pump, which was a very efficient roller pump, nearly a complete vacuum. And then a bespoke sort of controller box for the handpiece, and so that was the original Coherent morcellator. And of course, we, like most people, have moved on to the rotary models such as the Piranha, is probably one of the more popular ones. And the coherent one, I don't think it's being made any longer, but there are other morcellators, particularly with reciprocating blades, that have taken over. But I don't know if they've... do Boston still make a morcellator? Do we do? No. Not sure. But anyway, so they support it but don't sell it. Right. So 1998, we first published the first small series of HoLEPs, and this monograph 10 years later from the British Journal gives you a good example of what we were doing with the three-piece technique, taking out the median lobe between a couple of bladder neck incisions for a start, and then enucleating the two lateral lobes. And the artist got what we were trying to do and did quite a good job of that. So that was quite good visually to be able to show patients exactly what it was that you were doing inside there. But yeah, that was one of John Fitzpatrick's more important contributions to the British Journal. So we thought, and so did Coherent, that we had to do a randomised trial so that we could use the morcellator. We got halfway through that trial and they realised that they didn't have to do a randomised trial, and the morcellator would get 510K approval because there were already soft tissue morcellators in gynecology, and so they dropped us like a hotcake at that point. It took away all the funding and various things, and so we finished the trial off and funded it ourselves, and then we reported it out to 7 years. But that was the first of over a dozen randomised trials comparing HoLEP to TURP. And the findings versus TURP still apply today. More tissue is retrieved with HoLEP when compared to TURP. The truss volume and the PSA are lower than TURP, which is a reflection of the extra tissue which is retrieved. We did pressure flow studies in this paper before and afterwards and showed that there was better relief of bladder outflow obstruction than with TURP, and it was more efficient in terms of grams per minute. Less morbidity and more durable, so it seemed to win on every level. And then we've been through a whole range of different subsets in those first 10 years. The first large prostate paper we published in 2000, and that was 30-odd patients and that really opened the way for the large prostate experience. We looked at small prostates as well and showed that up to 30 grams whole bladder neck incision was just as good. But between 30 and 40 grams, we had several patients who required re-treatment with bladder neck incision, so we would always enucleate them. And we also tried some alternative energy sources, a bare fibre, a coil. The plasma kinetic was a bipolar product, and we randomised that to holmium enucleation as well. So we did a range of different RCTs looking at the various iterations, and then at this time, very importantly, there was their arrival at Jim Lingerman and Mustafa Al-Hilali were sort of vital in terms of the growth and the survival in terms of holmium enucleation in the States. Rainer Kuntz and who's the chap from Italy, Francesco Montorsi. Yeah, he was fantastic. There were half a dozen people that were really instrumental in then getting a little bit of momentum, and it was all around this same time. And as we know, every possible permutation and combination has been published many times over, and there is an enormous base of evidence to support HoLEP. So that's so in summary, the level 1A evidence supported by all the guidelines. It evolved in that stepwise fashion, constantly searching for more efficiency. Parallel development of the instrumentation was essential, and the procedure's now pretty standardised, whether you do 1, 2 or 3 piece, and no matter what you call your procedure, we're all trying to achieve approximately the same end goal, and a variety of energy sources have been used, and people have talked about an anatomical nucleation to allow for all those other energy sources, but in my hands, holmium remains the best of them. Thank you. Questions?
So Peter, you obviously were familiar with supercubic enucleation at this time, yeah?
Open prostatectomy, yes.
And you're developing this procedure. Was there a aha moment when you realized from going to a TURP or a HoLEP that all of a sudden you could go to a HoLEP?
Yeah, it wasn't like, it was over the space of, because when we started resecting, all of a sudden you were in that plane.
Yeah.
And, this is good. Oh, imagine if you could, it was really the tissue retrieval that allowed it to happen. And for all coherence problems, they did support us. I can remember there was a pivotal meeting down in Florida where the engineers and the bigwigs in the organisation they were really pushing for HoLEP as because they were worried about the rise of the green light laser, and they were making all the money and they weren't making any money, and it was but we finally convinced them, just give us a go, get us a morcellator and we'll see what we can do with it. And their board of directors decided to go down that path and get their engineers to work with us to make a morcellator. That was probably the moment where we could start to talk about enucleation in its own right, because we could get the bits out. Yeah.
Other questions?
So, we kind of all take for granted that I can talk to a patient about what the surgery I'm going to be doing is, what their risks are and whatnot. When you came up with this surgery, how did you explain to the patient what you're going to do? How do you recruit them to undergo something like this?
Well, as I say, we were, from one year to the next, we might have been talking about a different procedure in those early days. It wasn't like we were having to explain enucleation to the first patient in 1994. So it was seriously a stepwise development. It wasn't one day holmium laser enucleation wasn't there, the next day it was. So in terms of counselling patients, we would talk to them about the procedure of the day, which was usually, it had something to do with holmium. And I think we were pretty lucky in the fact that we didn't really have to go through a whole lot of regulatory steps to move from one to the other. And we were just able to evolve and do what we thought was most efficient. But we did go through a phase when we were waiting for the morcellators of really just enucleating back to the bladder neck and then getting out the resectoscope and chopping up these large lobes that were just dangling there and trying not to dislodge them until they had been completely... And still, I mean, if your morcellator dies in the middle of your case, you can still do that. And a lot of these things would hold you in good stead still today.
Thank you so much. I really enjoyed the talk and the evolution of what you're describing. I wanted to ask you a little bit about how could you tell us a little bit about how receptive urologists were to sort of like the new technique and what kind of things that were you hearing at that point about them adopting the field in general, just adopting it, and if you can contrast that to what you're seeing now with with the receptiveness of the urologic community in general to this technique.
Urologists it was one of those seeing is believing things. When people started to see these things, and I did a number of live surgeries. I could particularly remember I did one at Long Island Jewish, and it was part of the World Congress. and it was beamed back into the hotel that they were in Times Square. And so I was doing this HoLEP in the very early days. And that, for me, I got back to the thing and people would just come up and say, man, that was great. Have you ever seen anything like it? Well, yeah, but we've been talking about this for a while. Had you not noticed? and it was, yeah, it's one of those ones, it's a very visual thing. If you see someone do a slick HoLEP, you're seeing something that's a little bit unusual, and urologists are very supportive. But then the next question is, well, how do I learn? I've no idea. Yeah, there's no company that supports it, so and there's no organised training programs. So the people who've done that the best are the Brits. And they've got the HoLEP user group, and Tevaho, who's a former resident of ours. He's done a great job and sorting that out, and they've got a very supportive environment, and also the person who distributes the high-powered holmium laser there for Boston Scientific is very supportive in terms of facilitating courses and things. It's a great model, but they're the only people who've got it down to that level of sophistication. Yeah.
Just maybe a little bit more of an editorial. That seems really loud. I'm loud enough. I remember reading the 2005 article as a resident. And that was, there's like things that crystallize your experience. And we read that in Journal Club. And it just blew everybody's minds about the amount of tissue that you guys were removing in transurethral. And I think that my editorial is that for a lot of us, this feels like instantaneous revolution, right? Because we read an article or we go and do residency somewhere, and that's just what you do. But for those involved in being in the trenches, it's really an evolution that you guys went through of this whole process. And I think it's the 5th time I've seen the talk, but that that evolution is really evident in how you present kind of the history of it, and it's always so appreciative that you do this for us. So thank you, Peter.
Thanks, Joel. Yeah.
When I finished my fellowship, which was 2001, after leaving New Zealand, there were just a couple of us in the U.S. doing this. So to the point of what everyone is saying here, I remember Peter distinctly saying, do you want to be busy with, to start your relationships with industry, because he's like, because you're about to be very busy with Coherent. And we attempted all sorts of courses because it really was about the learning curve. So those early days, and once laser scope hit the market, then, we could tell you what the AUA was about. It was green light versus HoLEP. And it would just be, you would have your HoLEP group and you would have your laser scope green light group. And that was what all the sessions were about. And we would just argue back and forth. Like sometimes they would actually get, you remember those days, people would get really sort of very angry in the sessions about various different things because they're not the same technologies and they're not the same procedures. Yeah. And people were trying to categorize them into the same category and saying that these are the same, but they're not the same. They're different wavelengths, they're different everything. And it was, but they beat us on the learning curve. Like there was no doubt about it, like no matter what. And as Peter said, we would try these courses, we'd create courses, we would create video courses. I remember when Joel first got started doing it, I received his disc of recording and we actually, DVDs, and we actually critiqued each other, right? Like I would be given them to look at and say, do you have any advice? And I don't know that happened in the laser scope world. It may have, but it's just a different procedure. But we held ourselves to a standard that was somewhat daunting, I think, for people who wanted to do it new and had to figure out how to do it. So that's why it's interesting to be here 23 years after finishing my fellowship and having visiting professors and everything all about enucleation, right? Because it has been a long time coming. And now I think the biggest threat, if you will, and I don't want to say it as a threat because really we should just be striving for what's giving our patients the best outcomes, speaking as a previous chair of the BPH guidelines, is the reality is the residents are very, very comfortable with robotic surgery. So I think you add in aquablation and people who are comfortable doing robotic simples. And I think that's going to be the question of, are we now enough of a force of enucleators that will continue to play a role, or are people going to go right back where we went with laser scope, which is, we already know how to do this, this is easier. So it'll be interesting to see what your next version of evolution of HoLEP is in your talk, with the new players.
Well, there are new players, and the last part of my third talk is Andromeda, which is, they are looking to do a HoLEP robot, and we're going to do the first cases in a few weeks' time. So let's see if robotics adds anything. Certainly, if you can do it transurethral, you're always going to beat anything that's abdominal. And try as they might, they still have the catheters a bit longer. You do have abdominal wounds. The cost is a factor of 10 times greater to do it robotically in real terms, with real money, in jurisdictions other than the US, where the robotic people think very hard about doing robotic cases, other than prostatectomy in most other jurisdictions. But an endoscopic robot, now that would have all the same advantages of the standard HoLEP, and I can see that could be something. But let's see where the Andromeda one goes, and there is another company that's also doing transurethral surgery with a robotic angle to it, and I think they're looking at ablation. They're not looking at enucleation. So, yeah, there's interesting stuff coming, which just builds on HoLEP. It doesn't necessarily build on a robotic prostatectomy.
So the question John always asks me is, the TURP dead? He says, it's dead. Is that true?
No, TURP's good procedure. But you don't need to do it. But but if that's all you can do, you could do much worse. There are a whole range of new devices which are way worse than TURP that have just been recently approved, as we all know, which probably, in my view, are completely worthless. And TURP is way better than all of those, in my view.
I'll make a confession. I was on laser scope side at that time. and my epiphany came when, and I was a very big fan of seeing how far I can go, doing 300-gram prostates with the green light, and it works, But then they all came back bleeding, symptoms come back in just a few years, and I wrote a paper, basically saying this sucks, because of this. And I had to find something different. And to the point that Peter made, watching it made a big difference. So I went to the EAU one year, EUA, and I was watching a live surgery, and they were doing HoLEP. And I go, well, if these Europeans can do it, I can do it. And that's what made me pick up and go want to learn how to do HoLEPs. I mean, it really was watching someone do it and seeing the result that they get compared to what I was getting, was a huge mover for me. And on top of that, being on the BPH panels years ago, even back 15, 20 years ago, if you look at the amount of level 1 evidence, randomized clinical trials, for any of the surgeries we do, HoLEP always was like this much randomized level 1 data, and all of the others, green light like this, right? And it's not more evidence that we need. We need people to actually pick it up and do it. There's plenty of evidence out there. All right, moving on to our second talk, Dr. Wells, Shane Wells, is one of our faculty. He's primary faculty in radiology here. He's director of abdominal MRI radiology. He also has a joint appointment in urology because of the research work that he does with us. I asked Shane to give us a talk really about MRI of the prostate, because we all know MRI is the best way to look at prostate anatomy, and I'm hoping that he could shed some light in terms of the back and forth that we have, because I've yet to hear on where is the urethral sphincter. The bladder and neck actually connect to. And then you always hear these questions for HoLEP. Say, I do this, and then at the bladder neck, there's this fibrous bump that comes up. What is that? So I'm hoping Shane can shed some light by telling us about the prostate on MRI. Come on up, Shane.
Thanks, John. It's great to be here. Thanks for the invitation. So I have the enviable task of teaching anatomy to surgeons who are experts at anatomy. So I'll do my very best. I'm going to focus this on MRI and try to give you some basics to identify the pulse sequences that are important, right? I think it's often confusing when you pull up an MRI and there's 15 or 20 or even 50 pulse sequences and trying to pick the ones that you need to look at. And so there's really only two, and we'll get down into those in a moment. Okay, so I don't have any relevant disclosures. I have researcher relationships and funding through GE, Siemens, and Cook Medical, and do some consulting for Ethicon. All right, this is what the outline is going to look like. We're going to look at the imaging options, which you already are very aware of, and just to kind of discuss the overall strengths and weaknesses of each of those. We're going to do a very brief fundamentals of MR physics so that you understand how the images are obtained, and I think that'll help you pick the pulse sequences to review the anatomy. And then we're going to dig into T1 and T2 weighted MRI. Those are the important sequences that will demonstrate the anatomy that you need to be able to review. And then briefly at the very end, we'll talk about some of the research, the quantitative techniques that we're doing in collaboration with Dr. Wei and Dr. Delancey and Dr. Lane and others. All right, so here are the three imaging options that we frequently use for evaluation of the lower urinary tract, and those are ultrasound on the left. That's a transrectal approach, as you can see. CT in the middle, that's a non-contrast CT, and then that's a T2 weighted MRI on the right. And each of these modalities has strengths and weaknesses, as you know. So ultrasound, I think it has a lot of advantages. It's portable, it's accessible in the clinic, you can use it, it's cheap, and it's very safe. And importantly, it's real-time imaging. So you can evaluate things dynamically in real time to optimize the evaluation of whatever you're trying to look at. Often it's the bladder or the prostate. And then the contrast is really, really good. The disadvantages are there's a lot of variability between providers, and so that limits standardization, especially when you're trying to get reproductive imaging approaches or measure things in a reproductive fashion. It has artifacts, the field of view is limited, and there's a really steep learning curve, and that's what makes it challenging. Even in radiology, this is becoming increasingly an issue as our volumes go up. Trainees get their hands on ultrasound probes much less often. Now we can interpret the images very well, but we just aren't able to do the ultrasound as well as we used to because we don't get our hands on the probes as often. And in the upper right-hand corner, you can kind of see what the reimbursement is from a pelvic ultrasound. That just gives you some perspective as you order these tests to just give an idea of what they cost. So the technical fee from CMS is $105, and the professional fee is just around $20. All right, so CT, as you know, has the advantage of it's reproducible, it's safe, especially in the population that we're talking about today. The small radiation dose is not that big of a deal, and it's a relatively flat learning curve. You can learn the basics of attenuation. You know, stones are bright. You can see in the pelvis on the image on the left, there's a phlebolith there. Stones all look the same. They're all bright. Now, of course, their density can vary. The disadvantage of CT, it's not portable, it's not available in your clinic, and as you can see there, it's much more expensive. So essentially double the cost of a pelvic ultrasound. And the soft tissue contrast is just not very good, right? So those are images without and with contrast, and they look almost exactly the same. So it's very difficult to differentiate the peripheral and transition zones there. Now, you can get a delayed image, an excretory phase, and that allows you to see the urine in the bladder and the bladder wall better, but it's just not very good for the prostate. And then we move on to MRI, which I think is probably the best modality for evaluating the prostate and the bladder. It's reproducible. It's safe, although the safety checks that we have to do with patients are more rigorous because of the high magnetic field. So not everybody can have an MRI. The soft tissue contrast is exquisite, and it's dynamic and quantitative, although we haven't adopted those imaging approaches in benign urology yet, and that's some of the work that we're doing. The disadvantages are the access is limited, especially in the developing world. It's not portable, it's not available in your clinic, and it's expensive. But notice that the cost is just, the technical fee is the same as CT. And in fact, the professional fee for MRI interpretation is lower than CT. So MRI is the middle option as far as cost goes, compared, with ultrasound being the cheapest and CT being most expensive. With MRI, there's a relatively steep learning curve. And what I think is a real problem is the variability across institutions, right? So, our prostate MRIs here take about 30 minutes. We get essentially 6 pulse sequences, but some of our outside studies, they'll have 30 or 40 different pulse sequences and the scans last over an hour, and that's difficult for patients. And then there's artifacts you have to be aware of and always keep in mind when you're interpreting MRI. All right, so this is brief. I'll keep this very brief. So as you know, MRI is a very high magnetic field, and basically what it does is it aligns protons or hydrogen atoms. It's essentially like a battery. There's a positive and negative end. So when you lay in the scanner, there's a positive pole and a negative pole, and that aligns the protons. And then after you're in there, because at rest they're just randomly oriented. So you get in the magnet, the hydrogen atoms or the protons align. You apply an RF pulse, and this does 2 things. It changes the protons from being aligned with the magnetic field to a 90-degree angle. And then after the RF pulse is transmitted, the protons relax back to in line with the magnetic field. So in that positive, negative direction. And then the other thing that happens is when you apply an RF pulse, the proton goes to a 90-degree angle and then it spins, right? So it's spinning and relaxing at the same time. And those are the 2 things that you have to know about how imaging is obtained. And that's about all we're going to talk about when it comes to MR physics. And so these 2 things give you T1 and T2. And as you know, for anatomy, for us, T2 is the most important. T1 is what we use for contrast, when we give contrast. So I want you to be familiar with T1, just so you know how to pick the right sequence and interpret the image. This is a T1 image you see on the bottom. The prostate is dark, right? So if I go back 2 slices, this is a T2 weighted image, right? The prostate is generally bright. So that's one way to tell what your pulse sequence is, but that's not the easiest way. And notice that the fat is bright in this case, right? So we've talked about this. So we've talked about T1. Now let's talk briefly about T2. Now when you apply the RF pulse and the protons are spinning, right? They're in phase or they're coherent, and so as they spin the different soft tissues, the spin rate is different. So that's how T2 can differentiate the different properties, because the spin rate as the protons relax back down to in line with the magnetic field is different in the tissues. And when we hit it with an RF pulse, the proton spins, and then as it relaxes, we collect data. And depending on when we collect the data, the image will look slightly different. And so in soft tissues, like muscle versus fat versus prostate, what happens is the spin rate is different and the protons become not coherent, right? So they spin at a different rate, right? So that's the important thing to know when it comes to how T2 weighted images are obtained. All right, let's get into like interpreting the sequences or identifying the sequences so that you can interpret them. So the easiest way to identify a T1 weighted image is look at the urine, right? The urine is going to be dark, as you see here on the right. And notice that we can change the sequence or change the image. If you look at the image on the left, you can see the fat, the sub-Q fat is all bright, and on the image on the right, the sub-Q fat is all dark. This is still a T1 weighted image, so if we would look at the bladder, the urine is still dark. So that's just one thing that we can do to the pulse sequence to make it look different, even though it's still a T1 weighted image. The reason this is important, because there's only a few things that are bright on T1. One of those things is fat, right? So as we can see here on the left, the fat is bright. In the middle image, you can see that this patient has either protein or blood in their urine, right? You can see there's a layering bright level in the urine, in the bladder, and that's urine without protein on the top and layering urine with protein on the bottom. And then on the image right, you can see that there's blood in the seminal vesicle. So you see that bright T1 weighted signal. So those are the three things that we can see that are not contrast, that are bright on T1. So if you just remember what these things are that are bright on T1, it'll help you interpret your images. So what's most important for us, though, is that contrast is bright. And so, you know, on the image on the left, that's a T1 weighted fat saturation image. Notice that the fat is dark. And then the image on the right is we've given contrast. And so everything that's bright is either a blood vessel or active bleeding, for example, if we were doing a bleeding study. And then you can see anterior to the prostate there's that venous plexus or the vascular plexus, and it shows up very well on this T1 weighted post-contrast image. So if you want to know where the blood vessels are in proximity to the prostate, choose your T1 weighted post-contrast image. And here at University of Michigan, we do dynamic imaging. So that's a stack. It's usually a stack of images. You can scroll all the way to the very end, and you'll be able to see the post-contrast image and be able to understand where the vascular anatomy is relative to the prostate. All right, let's move on to T2 weighted image. Pardon me, one last thing. Stones are not bright on MRI. Okay. So like CT, the stones are bright. On MRI, the stones are dark, right? So this patient, you notice on the T1 weighted image that the stones are dark, the urine's dark, so you can't see them. But on the right, that's a T2 weighted image. You can see the urine is bright, and you can see stones layering, you know, in this prostate. And I think this patient probably had a TURB. So just keep that in mind. Stones are not bright on MRI. All right, so T2 weighted image, as I mentioned, bright urine. So keep that in mind. That'll help you identify the sequence that you want to review. And this is the most important one for anatomy. Now, again, just like T1, on T2s, we can saturate the fat out to make the fat dark, right? So you can't always look at the fat to identify the pulse sequence. Look at the bladder. Notice compared to the T1 weighted image, the prostate here is bright or heterogeneously bright, especially in the transition zone. But notice how the prostate signal changes from the non-fat sat to the fat sat, right? So oftentimes what happens when you apply a fat saturation pulse, things that aren't fat get brighter, and that's just because the signal, the computer associated with the MRI tries to reset the intensity levels, and because of that, things that aren't fat just get brighter. Okay, so let's start looking at some of the anatomy that we can identify in the prostate on T2 weighted images, right? Those are the most important for identifying your anatomy. And this is an axial image, right? So just like your CT. And so the peripheral zone is bright. I think we're all very familiar with that. And that's related, the bright signal on T2 weighted images is related to the fluid content, right? So things that have more fluid are brighter, things that have less fluid are darker. And as you know, that's the transition zone there. That's the transition zone there, and it's a combination of epithelial and stromal changes, smooth muscle fibrosis. A lot of things are going on in there. We can't really tell the difference between those things with MRI. They're either bright, so they're epithelial, or they're dark and they're stromal. That's kind of how we see it. And then anterior there at the level of the midgland, you can see that really dark, small structure, and that's the anterior fibromuscular stroma. It's fibrous in nature. So on MRI, anything that's fibrous tends to be very dark. And I think that's important when we think about the capsule, because we can generally see the capsule as a very thin, dark T2 weighted line. Let's see. So this is a coronal image. I just want to orient you. This is a coronal image, and there, there's the bladder, and you can see the bladder wall is a little thick, and there's some trabeculation, and there's the central zone. So compared to the peripheral zone, the central zone is dark, more similar to the transition zone. But I think I think you see it best on the, so I'm sorry, on the image on the left is an axial, image on the right is coronal. I think you can see the central zone much better on the coronal view. And you know, when you're trying to differentiate cancer, I think it's really important to look at this sequence to see where the focus of dark in the peripheral zone is. You can see it has that Y shape, and that's the central zone on a coronal image. And there at the very bottom is the base of the penis, and then above the level of the prostate are some of the seminal vesicles. Okay, and so back to axial images. Here again, we're still in T2 weighted images. You can see there where that little tubular dark structure anterior to the seminal vesicles is the vas deferens, and then I pointed out what the seminal vesicles look like there. That's posterior to the bladder and above the level of the prostate, as you know. And then at the level of the prostate base, you can see these two paired structures, these two paired T2 bright structures. Those are the ejaculatory ducts. And on the coronal image, you can see those coming down from the seminal vesicles into the central zone of the prostate. And you can follow those down to the level of the verumontanum, which is the urethra. The prostatic urethra is collapsed, so we just do not see that very well. I'll point out that this dark T2 line right here, the urethra is centered right there, but it's very difficult to see the urethra unless there's something abnormal in the prostate. So I just wanted to kind of give you an idea of what the mid-gland of the prostate looks like in a patient without significant BPH on the left, and then with various different types of BPH in the others. And notice that each one is unique, right? The lobar hypertrophy that patients experience, all of them are very unique. The amount of stromal and epithelial components are unique to every patient. So from a radiologist standpoint, qualitatively evaluating images, it's very difficult for us to group patients into buckets, like if we were trying to phenotype patients based upon qualitative images like these. Okay, so, oops, wrong button. All right, so let's move from axial images here to sagittal images, just to get an idea of where the course of the urethra, how that might change in relation to the hypertrophy pattern in the transition zone and the location of adenomas, BPH nodules, and et cetera. So as I move to sagittal MRI, the patient on the left is kind of normal. The bladder wall looks a little thick, but there's hardly any post-void residual, and the prostate is small. Again, we can't see the prostatic urethra well, and we can kind of guess where the sphincter is based upon the position of the pelvic floor or the urogenital diaphragm. I'll show you a better picture of that next. But then notice the other patients who have BPH-related changes and adenomas, how that affects the bladder, the angle of the bladder neck. And then, you know, what's commonly used with ultrasound is to look at the degree of protrusion of the median lobe into the bladder. But that can also be done with MRI, although I don't think we do it frequently. So as you can see there, this patient on the right has a large median lobe, and there's a substantial extension into the bladder base there, probably 2.5 centimeters or so. And then notice how the bladder wall thickening and trabeculation changes are different in these patients, you know, and the degree of post-void residual, which can also be quantified on MRI. So this is, you know, to John's point, this is our best attempt to understand where the sphincter or the membranous urethra is. And we do this for our prostate cancer patients. The sagittal MRI, I think, is very difficult to see the muscle. What we have to do in real time is we have to scan through the pelvic floor, the urogenital diaphragm. We have to scan through and kind of identify the muscle, and we use the muscle as the reference for the length of the sphincter. On the right, though, image on the right, that's a coronal view. I think you can see the muscles very clearly right there, right? So you can see the prostate's enlarged. There's some bladder wall thickening, not a whole lot of post-void residual, and then there at the bladder, at the prostate apex, those dark T2 or those dark T2 lines are the muscle or the urogenital diaphragm, and that's where we tend to try to measure the length of the membranous urethra or the sphincter. And in this patient, what we try to do is measure from the apex of the prostate to the spongiform of the penis. So I'll point it out to you here. So we tend to try to measure from about right here to where we see the base of the penis. And so that ends up being the length of the membrane through right there, the sphincter. That's how we do it. So go ahead, John.
So the dark color, that's the muscle itself.
That's right.
What is the white outline around? Is that mucosa?
This white outline here?
Yeah.
Oh, that's fat.
Fat.
Yeah. This is fat right here. Notice that all our subacute fat.
No. On the medial side.
Oh, medial side right here.
Yeah. Right where your finger was. The prostate adenoma, and the apex of adenoma.
Right there. Yeah. I think that's also fat. Although we don't get a coronal T2 fat set to prove that, but I think that's fat. Because the urethra, you see this dark line right here?
Yeah.
That's the collapsed urethra. This dark line right here.
So where's the capsule?
The capsule.
Prostate capsule. Like relative to the sphincter, where's the capsule?
It's really difficult to see. Yeah, we see the prostate capsule best on the axial image. So if I go back a couple to get you an axial image, we can see this dark T2 line. That's and we can actually on an axial image if you bring you scroll down towards the advance, I think you'll be able to see that. I don't know exactly where it terminates though. In your experience, let me go forward. Does the capsule terminate on the sphincter?
I think it's indistinguishable. It's been chimed in. It's really indistinguishable. We see something that looks fibrous, and I always tell the residents that's the end of the capsule there. And I don't see any circular. I try not to see anything that looks circular fibers. That could be more urethral.
Yeah, we don't see these circular fibers at MRI, although we can see them in ultrasound, the circular fibers. But we don't often use ultrasound to evaluate that intent.
So the end of the adenoma in this image, so the sphincter looks like it's half a millimeter, half a centimeter.
The distance from here to here?
To the muscle.
Oh, here to the muscle?
muscle.
I would say that's about right, 4 to 5 millimeters. Any other questions? Okay, and as we know, the bladder remodels in response to these high voiding pressures, and this gives you an example of all the different types of bladder patterns that we see with MRI. And notice the patient on the far right has, thin wall, trabeculation, and diverticula. So that tends to, what we see, it appears to us as like the end stage of the bladder. All right, so we'll move into, in my last couple minutes, the quantitative, some of the quantitative work we're doing. So what quantitative imaging is, it's the extraction of measurable data from images to assess severity, change, or status of a disease. And so for patients who are on medical therapies, we think this might be a really good approach. We don't use this a lot in lower urinary tract imaging. I think post-void residual and prostate volume, those are the kind of the things we use now as reproducible biomarkers. But some advanced techniques can be used to characterize a variety of things, including tissue signatures, cellularity, stiffness, perfusion, and function, among others. And these are qualitative images here, so this is just kind of, you look at it and it looks different. That's our approach here. This patient was on 5-AR therapy. You can see the prostate changed in size and appearance over time. The epithelial component has decreased. The prostate got smaller. I think we all know that happens. We don't have to image those patients. However, one of the pulse sequences, the quantitative sequences we've developed are these T1 and T2 maps. And what they take the qualitative images a step further, right? So these maps measure the true T1 of tissue and the true T2 of tissue, right? The images on the left are on a spectrum between T1 and T2. The images on the right are not on a spectrum. They are at a very precise location. And so we can reproduce this image and measure put a region of interest on the transition zone and measure the T1 and T2. And we think that might be useful in patients like the one on the left. If a patient has a high T2, that patient may be more responsive to a 5-AR therapy. So if you got a prostate, got this before You see a patient with lower urinary tract symptoms, you get an MRI that includes a T1 and T2 map, and you put a region of interest on the T2 map of the prostate, and the number is high, then that patient may respond to 5-AR therapy. But if it's not high, then it might allow you to avoid that step. So that's where we think that might be useful, although we're still in the early phase of doing trials to support this idea. This is a concept we use now in prostate cancer imaging, diffusion-weighted imaging. It lets us know what the cellularity is. So things that are dark, so on the image on the right is an ADC map. Things that are dark are highly cellular, right? So this is how we interpret prostate cancer images. We look at this ADC map. Things that are dark, we worry about being cancer, all right? Often those are in the peripheral zone. In the transition zone, prostate cancer and BPH look exactly the same. They both have a low ADC or dark on ADC. This is a stromal nodule, but an epithelial nodule is not very cellular at all. So on this ADC map, an epithelial nodule will be bright. So layering this into a T1 and T2 map might help us understand what the cellularity of the transition zone is. And this is work that we have a couple small grants on, and we're seeking NIH funding to pursue this idea further. This is estimating the stiffness of the transition zone. So we apply waves and we measure displacement of waves in the prostate with MRI, and it gives us a map of the stiffness of the prostate. And this is one example of a patient with mild lower urinary tract symptoms. You can see that the transition zone circled in black is stiffer compared to the peripheral zone, which is circled in white. But notice that in the center of the transition zone where the urethra is, notice that there's relatively spare. It's relatively spared, so it's not stiff. So I'll point it out to you. Right, so this is transition zone, this is peripheral zone, and this is where the urethra is. And notice in this patient, there's sparing, right? The tissues around the urethra are not stiff. So we think this could be helpful. Maybe this is why this person who has a larger gland and a stiff transition zone is not very symptomatic, because his urethra is able to expand more than another patient who might have a stiff periurethral tissues. And then this is some of the dynamic imaging we're doing. And so a patient's voids in the scanner, and we can measure the change in volume, and from that we can estimate pressure both in the bladder and across the urethra. That collar flow 3D map on the prostatic or the penile urethra, it represents flow rate, right? So areas that are red have a high flow rate, and areas that are blue and purple have a low flow rate. And notice in this patient who's normal, their peak flow rate, which is red, is at the level of the UG diaphragm or the sphincter or the membranous urethra. Right here. And so we have other examples where patients that are abnormal, have abnormal bladder function, that their prostatic urethra is much more narrow, and the peak flow rate's in the level of the prostatic urethra rather than the membranous urethra. And then the image on the right is using T1 and T2 maps to understand what the bladder wall signature is, or what changes are occurring in the bladder in these patients who have BPH or detrusor underactivity or overactive bladder, things like that. So that's some of the work that we're doing in collaboration with the urology group, including Dr. Wei. So in summary, MRI is a great tool to evaluate the lower urinary tract. Mostly we're doing qualitative work, but we're hoping some of these emerging quantitative techniques will help you take care of your patients better. The major focus is, can we triage patients to surgery sooner? Instead of keeping on patients on medical therapy for a long time, and that negatively affects their bladder function. Access and institutional variability remains a challenge for MRI, but importantly, the cost is not higher than CT, which I think many people think. T2 weighted sequence is best for the anatomy. Remember, things that are very dark are fibrous, things are bright are more epithelial or more fluid-filled tissues. Look for bright urine. Use a combination of your axial, coronal, and sagittal images to identify the anatomic structure that you're trying to use those different planes to best identify your anatomy. And then the T1 weighted, remember that's dark urine, use that to identify the vessels that are of interest. All right, thank you. Yeah, sure, John. Yep.
So how come it's so grainy?
So I didn't want to get into the details of this sequence, but thanks for pointing that out. This is actually, you remember the rule is bright urine is T2. This is actually a T1 weighted image, and we've given the patient contrast. And the reason and we're working on getting a T2 weighted sequence so we don't have to give contrast to the patient, because ideally what we do is bring the patient in, it's a 30-minute exam, no IV, in and out. That's what our goal is. The patients, when they get an MRI, you can stimulate their peripheral nervous system if you image them too hard. And so our T2 weighted sequence, that's where we are right now. Patients get peripheral nerve stimulation and it's painful. And so we haven't been able to use the T2 weighted sequence yet. So we've done this with T1, but it is grainy, I agree.
So I'm wondering, is it possible while they're voiding or have them interrupt their void so that you can see the external sphincter muscle contract and see where that is relative to an adenoma?
Sure.
Can you get that level of detail? Because when we do our scope, we'll take the scope past the sphincter, we'll tell patient contract, you can see it contract, and we're guessing on our mind how far that is from the viru and from the apex of the prostate. This sort of dynamic picture will actually clearly show us where the functional sphincter is and how far that is from the actual adenoma we're trying to dissect. Is that possible?
I think we could do that. You can see that the middle image there, you can't see the prostate well because this is T1. So I think what would be helpful is if we could change our approach to a T2 weighted image so we would see the prostate better. And then we would see the membranous urethra, the location of the membranous urethra better, and then I think we could give a really good image. So we can work on that.
There's just so much to talk about here, but Casey, you might just have to wait to start your presentation. But anyway, it's this reminds me of how they did the German couple that was in the MR having sex, and Goldstein would always talk about like looking at how things functioned when they were doing it. So the voiding supine is its own sort of issue.
Yep.
But something of all the things that I would love to talk to you about offline, the one thing is you mentioned the stiff urethra. So one of the things we know about untreated sleep apnea and that sort of the ischemic model is that you get free radical damage and oxidative stress in the actual prostate. So it actually makes the prostate stiff and less compliant. So when we think about this model as opposed to it all being related to BPH, and I'm not saying that treatment isn't still reduction of the outlet, but it's a different sort of picture. So if you do look at that, and I would love to be part of that study, because we do a lot of the sleep apnea, putting rats in an oxycycler and things like that to understand that. It triggered me to think how this looks different in different types of models. If you're able to get that kind of granularity, it may change a little bit of the paradigm of how we approach some and how we approach them medically.
Are the patients related to the development of fibrosis, urethral fibrosis?
Right. So the oxidative damage that happens makes compliance or elasticity, right, which is a collagen kind of model. It's just not as stretchy. Constructive picture is not related to BPE, benign prostatic enlargement. It may be to the functionality of the urethra. This is the stuff that we don't know. Like this about we only know an animal that is just how BPH evolved over time, and the reality intellectually know there's more to it, anatomic issue that there are cellular changes, and we look at those right. Like we know that there are cellular changes. We've published about it. We've looked at it. Whatever. There are anatomic changes, and it's a matter of putting them together, which is very hard to do. So you have proposed to sort of marry those two things in a dynamic way, shift how we treat different patients. That's where we need to go, the treatment of outlet issues, right? Be able to discern in the environment of so many we can come at it. We can't just do categories. There's medications in the I think we need to understand who goes where and what are the best options for them. Their function.
Sure. Yeah. Yeah. Thank you.
Yeah. Thing to see what that segment actually looks like on an MRI. You know, one of the things that I think we kind of wonder is that why is it recover their continence so quickly in some patients, longer time, and there are factors like age probably play into that too. But if there are anatomical differences, are actually accounting for it. Very short segment not do as well as a patient who has.
I think that's right.
And I to kind of look back and kind of see it. You know, I used to do like ultrasounds just to take a look at this area, just to measure that area. You can measure it on ultrasound, and it's interesting. It's usually around 1 centimeter or so.
Yeah.
But there are patients who actually have really long segments, like even up to like 2 centimeters of length on ultrasound. I've never had, like, you know, obviously the kind of practice that can actually correlate that back to a surgical result, but you guys actually have something which is pretty powerful here, which is a lot of data and the clinical follow-up to actually determine if these anatomic differences actually result in a functional difference.
I think Matt Davenport and partners in urology have looked at that specific question, and just as you mentioned, the 1 centimeter cutoff seems to be very important, or around 8 millimeters in length. So I think we have looked at that once, and there's a publication I can share if you'd like, that, you know, a fairly large retrospective study. But I think it has to do also with, you know, fitness, patient fitness, right, and strength, you know, and maybe that bulks the muscle, you know, that maybe provides bulk to the sphincter as well.
And just a very practical question. You talked about measurements, you know, sphincter length, membranous urethral length. In terms of prostate measurements, and we know that ultrasound and MRI are both pretty good at estimating prostate volume. CT is obviously a lot more challenging, and it's hard to see kind of where the apex is. Any advice or practical tips for getting good measurements based on CT? Because everybody's had a CT, not everybody's had an MRI.
Yeah, it's really tough to you know, because if I go back to that very beginning where I had a couple CT images, just so everybody can see what it looks like. It's very difficult to differentiate the pelvic floor from the prostate at the apex, just as you mentioned. And so what I do when I'm trying to estimate the prostate size off of a CT is I use the sagittal, and I try to identify where the pelvic floor is, because what I've noticed most often is we undermeasure the length of the prostate, you know, the craniocaudal length of the prostate. And so what I try to do is I try to find the pelvic floor, which is this muscle here. I try to find that on the sagittal view. And it's, as you mentioned, it's a very variable thickness, right? And this patient on the right is not very fit, right? The muscle is very thin. And so what I do is I bring the axial and the sagittal up. I find that muscle in the axial. I co-localize it on the sagittal image, and then I try to follow it as, you know, as it comes. You know, it tends to be oriented in this direction as I come back to midline where the prostate is, and then I try to measure from there up to the base, and then I use the axial CT to check where my measurement is. So it's a lot of back and forth with the axial and the sagittal image, trying to find where the true apex of the prostate is. As you can see here, it's relatively easy to measure the transverse and AP dimension on the axial image. It comes down to finding differentiating the apex in the pelvic floor. Yeah.
Hi, Ann Cameron. Julia Ippolito and I talk about overactive bladder like every single day. So I was really excited when I saw the bladder images that you were showing. And again, you know, it's really interesting, the concept between, you know, changes in the bladder that occur with obstruction. I would really love to know the answer to the question, is this guy, based on his MRIs, detrusor overactivity and urgency going to go away after you debulk him? how much collagen is there, how much nerve fibers, and does this guy need a prophylactic botulinum toxin injection at the time of his TERP, or is the tincture of time going to fix this guy? Or should we move to sacral neuromodulation in this man because he has more of a neurologic phenomenon than a muscular phenomenon? And I know that's going to be like a 3-hour conversation, but I just throw that out there because to me, that's what's really interesting about the bladder fingerprinting you can do, because if we're deciding between a $30,000 implant and a $10,000 injection, I think it's worth the cost of an MRI to phenotype someone better.
Yeah. Thank you for that. That's work we're trying to do right now. A lot of this. So the image on the right is a movie of a T1 map of the bladder. So bright here in this case is urine, but you can see the bladder wall. This is a sagittal image, so you can see the bladder wall well and the prostate. And that's exactly what we're trying to do, is quantify the differences in T1 and T2 in the bladder wall, and then correlate that back to what is truly pathologically abnormal in the bladder, and then use that as a reference to get for your patients prior to making a treatment-related decision, so that you can have a better idea of what the true underlying etiology is for the symptoms, with or without the pressure flow studies. So that's exactly what we're trying to work on, and we've shown it in overactive bladder. Patients with overactive bladder have a shorter T1, and patients with diabetic bladder have a shorter T1. So we've shown that already in 2 different cohorts of patients, relatively small studies, but we're trying to expand that now. Yeah.
All right, moving on to the next talk is Casey Dauw. Everyone knows Casey, who's from Michigan. It's shocking to me that Casey graduated almost 10 years ago now. And I still remember when he left to go to Indiana to do his endourology fellowship, Stuart Wolf asked me, can he come back? I go, of course he can come back. He goes, no, when he comes back, can he do BPH? Because back then endo was only stones. And I said, yeah, the more the merrier. So Casey comes back and starts doing HoLEPs and does a ton of HoLEPs. And I've been grateful ever since. I mean, if Casey didn't do it, I'd probably still be a lone, depressed urologist doing HoLEP by myself. But he really brought a lot of enthusiasm and interest, and for that I'm forever grateful. So Casey's going to tell us about the classic Gilling approach. This must be tough with Dr. Gilling in the room, so do a good job. And then the next series of talks is really about surgical techniques and variations on the theme. Casey?
Great, thanks. Excellent. Thanks for the introduction. It is humbling to think that it's been almost 10 years now since leaving residency. Really great to see some people here that I haven't connected with in a super long time. I think a little bit of a preamble is important here, and so I'm presenting a technique. I think everyone in this room learned a technique and has probably deviated slightly from the way that they were taught. I don't really adhere to a technique anymore. I kind of take what the prostate gives us, and I think as people are learning, it's probably the most important thing that you need to have bailouts along the way that can help you if things are getting derailed. And so certainly the Gilling approach is how I was taught with Lingeman's modifications, but I would be a big proponent of learning multiple different ways to skin a cat, so to speak. So here are my disclosures. The ones that are relevant are I am a consultant for Boston Scientific and Cook, as well as Storts, who are in the BPH game with HoLEP. I don't do any work with any of those entities related to BPH work. So I don't really need to go through this anymore. Dr. Gilling gave a great talk about kind of the genesis of and the start of the HoLEP technique. But I do find it fascinating that we're still talking about a technique that was developed in the early to mid to late 90s and still considering that the gold standard. And I think that's really a testament to what was done back then, but also just how much tissue we're removing. It's truly an anatomic enucleation. I think that's the key. No matter how you do that, whether it's with the holmium laser, which we're going to spend a lot of time talking about today, or with a bipolar resectoscope loop, if you're enucleating, you're enucleating. There's multiple ways to do that, and that's the fundamental key. I'm presenting the Gilling approach, I hope. Maybe you'll be the judge of that. But I was Lingemann trained. And as I said before, I don't really use this technique too heavily anymore for a couple reasons, and we can talk about that as we go through the videos here. So just presenting a case here. This is kind of, I would say, our garden variety case here in Southeast Michigan. This is a relatively young man, which I'm usually excited to see, who's failed multiple voiding trials. He's unable to do intermittent cath because he's developed recurrent clot retention. PSA is relatively modest given the fact that he has a 220 cc prostate. He has had cystoscopy done by another urologist, which showed a large median lobe. This is my general OR setup. So I use a Storz scope. It's 26 French. I use a laser obturator and a laser stabilizing catheter. This is very standard. I don't think that I do anything much different than many of the other folks here. I do prefer the 26 and would love to have a 24 French scope, to be perfectly honest, relative to the 28, which I think is a little bit more traumatic for the urethra and for the sphincter. But certainly that's being done quite commonly too. So the way I'm going to take you through this is just a series of videos that represent key steps of this particular case, and they're presented in sequence. This is the only one that's accelerated to 2 times speed because I just wanted to give you a general sense of what we're seeing. So heavily trabeculated bladder, you can see a large kind of protruding median lobe. My only goal here on initial inspection is to make sure that we're not dealing with any bladder tumors or bladder stones that we didn't suspect, get a sense for anatomy, length of the prostate. I don't really pay too much attention to trying to find the ureteral orifices here, especially in the setting of a really large median lobe, because I think you're just going to cause trauma as you're looking for them, and they will present themselves later on in the case if you're meticulous and you stay within the bladder neck during your enucleation. So these are actually images from the BJUI article that Dr. Gilling referenced. And so I'm trying to provide a pictorial representation of what you're seeing there on the screen. So I'm working here at 2 joules and 50 hertz, so 100 watts of power for my enucleation settings. I am using a Moses 2.0 type of laser that's optimized for BPH. And what you can see is I'm just trying to find as best of a groove as I can here alongside the median lobe. My first move is to take this initial incision down to the level of the bladder neck fibers. I think once you can identify the bladder neck fibers, you'll often find, especially in the setting of a large median lobe where it's protruding into the bladder, that then you're going to move more distally and find where the prostatic capsule is going to begin to develop inside of the bladder neck. So trying to be systematic here. Lingaman would often say you pay as you go with these larger glands, meaning that you want to get as good a hemostasis as you can as you're going along because they can magnify and catch up with you as you go along. But you can see that I'm now kind of inside the bladder neck, and what I'm hunting for now is some representation of the prostate capsule. As you can kind of see those, in my mind, those vessels become more horizontally oriented as they're penetrating through the capsule. That's my general sense that I'm kind of beginning to find it. So you can start to see your first glimpses of the prostatic capsule there. Just a couple little layers of adenoma that need to go down. And really, as you're getting hemostasis in this context, it's really important that you wait until you're at the capsule because you're kind of like pissing into the wind trying to get hemostasis if it's all adenoma bleeding. Again, just trying to find the capsule as we go and taking myself distally back towards the level of the verumontanum, which you're going to see there medially. And that kind of indicates the distal extent that I need to go before I start making an apical incision on either side of the gland. So the next step of, at least how this was described, is that you need to make an apical dissection on either side. The apical dissection was already done on the screen right, the screen left here. What I'm doing now is on screen right, or the patient's left-hand side. I'm cutting just proximal to the verumontanum, taking this incision down to the medial incision that I've already created, and I'm just sweeping laterally with the scope gently to try to lift up that adenomatous tissue and find a very satisfying capsular plane here. This motion here is very much a blunt push laterally, but recognizing that the prostate is going to begin to deviate anteriorly around the side, you need to make sure that you're not extending your push completely laterally, or else you can begin to rip into the sphincter. And so, as you can see now, my scope fiber would be oriented up towards 3 o'clock, and all I'm doing here is lifting the prostatic adenoma off the prostatic capsule, trying to keep my laser fiber parallel to the capsule as I'm doing the enucleation. So I've done this on the screen left along with the median lobe. I've done this on screen right. My plan here in this case is that I'm going to take the median lobe and block with the left lateral lobe. So what I'm doing now is you can see that I'm carrying my screen left, or patient's right-sided apical incision anteriorly. So now I'm moving up to probably around the 10 o'clock to 11 o'clock position. In the classic Gilling Lingaman approach, one would actually take this incision all the way over the top of the adenoma and actually enter the bladder neck anteriorly, at the 12 o'clock position. My concern with this approach is that there's a easy temptation that if the plane is good, you can actually begin to come down the contralateral side. And in doing so, you're really tensioning the urethral sphincter, in my opinion. This is also a really challenging plane to maintain as you're learning because unlike what we saw posteriorly, the capsule actually can take various tracts anteriorly. And so I think that the way that I've moved here is I really just take my apical incisions up to around 10 o'clock and 2 o'clock at most. And then I can actually come back and under vision take the mucosal strips rather than encircling, which is a step I'm going to show you in this video, which is something I no longer really do traditionally. One other point of context, rather than entering the bladder neck anteriorly, which I think again can be challenging to find your plane in an up-down orientation, either diving into capsule and even in an extreme case above the bladder neck, which is not great, or diving into adenoma. I think that once you've established the plane and you've then taken your apex under direct vision, just making a simple commissurotomy 12 o'clock incision is going to define your plane. If you want to go back to that 2 or 3 lobe technique, you've then kind of defined all of your possible boundaries, and you're not in any circumstance cutting towards an unknown. And so that's kind of how I've deviated a bit. So moving on, this is your anterior commissurotomy. What you can see is doing this in a more traditional sense. I'm cutting down now here, trying to find my existing plane from below. One thing you'll notice in these very large glands, which is a hallmark of a large median lobe, is that the anterior commissure is often very attenuated. You often don't have too much anterior adenoma when they've developed a huge, large median lobe. So what you're seeing here now is I'm just, cutting down to the bladder neck fibers, finding the level where it seems that the lateral lobes are connecting to the anterior commissure here, and then attempting to divide these bladder neck fibers, which you can see here are kind of those fibrous, vertically oriented fibers. Had you done this in the more traditional fashion, you would have done this popping into the bladder neck. And again, I find that that's a little bit more challenging. So we would then do the exact same thing on the other side. And now really all we need to do is connect the dots. So we have a plane that's coming up from below from our apical incision, and then this plane that we've brought down from anteriorly. And so really this is the part of the case where you can begin to really gain some momentum because, rather than being tentative with your cutting, exactly where you're moving to and can use a fair bit of blunt dissection here. So laser energy, blunt dissection, and really just trying to take these long arcs from your bladder neck incision all the way back to your apex. At this point, if I was adhering to the Gilling or Lingaman technique, you would still probably not have liberated the urethral sphincter, the mucosal strip at this point. So for the purposes of sticking to the technique, I do believe in these videos, I've left a small little bit of strip that you can come back through and see at the viru that I'll divide. But again, you can see that this is just systematically taking my incision from the bladder neck distally and towards the apex. I should say I am a proponent of using the long pulse waveform and the non-Moses modes for hemostasis. So I use 2 joules and 20 hertz for hemostasis. I've goofed around with a million different settings, and I find that provides the best hemostasis for me personally. I do think that on first pass hemostasis, it's beneficial to use the Moses settings, so you're not cleaning up quite as much. But for point cautery, I definitely use just a long pulse waveform. So what you're seeing now, I believe, is that I'm beginning to encircle this lobe here. The goal being that there's a small remnant of anterior tissue that I'm pulling across the midline, which is the mucosal strip. You can see that that's come across my screen here. I think the pitfall with this approach potentially is that you're really distracting this off the urethral sphincter. And you can see I took tension off that to begin to cut it. But certainly as you're learning, this is kind of a hairy part of the operation because you're really bringing this right next to the mucosal, the urethral sphincter, which is immediately to the left of the screen right now. So now what we're moving to is just the posterior dissection. So this lobe is completely freed up. You can see that's bladder neck there at the top of the screen. And really the only thing that we have to divide is the posterior attachments. We've taken the plane down completely laterally, and we have a midline that's already been cut at the beginning of the case. So this is, again, a part where you can really gain some steam. You're just trying to use your laser energy to cut along the capsular plane, and your motion here is working upwards towards the bladder neck, with the goal then that you would divide it at the bladder neck. Yeah, I should have put music to this. That music out there is fantastic. That's spectacular. So again, just meticulously dividing these fibers here, you can see that we're going to pop this thing up into the bladder. I haven't still at this point identified the ureteral orifices. You can see that unless they had an ectopic ureteral orifice, which would probably get burned down either way, as long as you're working within the bladder neck, that's what I continually am telling the trainees, the likelihood that you're going to nail the ureter is really low. So again, just working this thing up, you can see that the patient has a really nice plane here, and you can begin to see that these fibers are changing just ever so slightly to be more like bladder neck. And once you get to that point, it's really just final cuts within the bladder neck to avoid the ureteral orifice. So this last step here is just division of this last little bit of bladder neck that's remaining. I typically at this point, when I'm about halfway done, will go back through the side that I've just enucleated and made sure that there's no significant bleeding, arterial bleeding that you just don't want to have to deal with later. And then we're going to move on to the other side. This is the exact same approach that we took. So again, I'm moving, this is my anterior plane here. I'm working between, let's say, 1 o'clock and 4 o'clock. The lobe is already pretty well freed up there. There's the viru there to your left, and I'm coming back through and again letting that mucosal strip, which is that last little bit of attachment, drop through. Again, I think this is a totally appropriate way to learn. I think one of the frustrations of doing BPH surgery like this is you can do the best surgery possible, and you're still going to have outliers who might have a little bit more prolonged incontinence. I can't say that I've noticed a ton of difference in continence rates moving towards a more early apical liberation approach. I think there's some forthcoming data that would suggest that the end block or early apical release approach is faster and may result in earlier social continence, but intuitively it just makes sense to not stress the sphincter. And so then again, this is the posterior dissection of the left lobe. Again, I'm taking the median lobe with this lobe because they were not separated in the traditional 3-lobe technique. I think I just do that for speed of the case. As you're learning, I think one of the best things for trainees to do is learn how to take the median lobe out in a 3-lobe technique because the planes are right in front of you. There's no apical dissection that's necessary, and it's a pretty intuitive enucleation. But again, in this case, this is a 2-lobe technique, but with a 3-lobe prostate. So for the sake of moving along here and not watching paint dry, we'll move on to the bladder neck release here. So again, I'm working with the scope and trying to maintain good visualization as I pop up this lobe into the bladder, leaving us with just a couple bladder neck fibers to divide. Again, trying as hard as I can to work within the bladder neck, then knowing that even if the ureteral orifice is close, that the likelihood that I'm going to cause any damage to it is really low. I am a big proponent for pretty aggressive hemostasis. I don't tend to use any electrocautery. I think that the laser is a perfectly adequate tool to get the hemostasis that you need. I will spend as much time as is necessary here so that I can sleep at night, frankly. If you're going to be doing a same-day discharge with a voiding trial, I think that this is mandatory and take as much time as you need. There's also nothing worse than morcellation when you can't see. And so, well, actually, the worst thing is watching a resident do morcellation when you can't see. And even worse than that, probably with how well John is training our fellows, is watching a fellow do this, which is what I tend to have to do. So I will spend as much time as is necessary here. If you want to use cautery, Wilson, you can absolutely do that. I think it's probably unnecessary, but you do you. And I think that this is definitely an important part of the operation, and there's no reason to rush here because this is where you may lose everything, even though you've done the slickest operation to this point. Everyone's favorite part of this operation is morcellation. I say that completely tongue-in-cheek. This can be quite painful. The morcellator is one of the most finicky pieces of equipment that we use. I think that I've found a setting that I think has optimized it as best as possible. In this particular case, it was fantastic. We were morcellating at like 14 grams a minute, which is awesome. But there are some really painful cases. Actually, Shane, one of the things that I keyed into on your talk the most is, maybe Shane's left, is the fibrous versus epithelial components of the prostate and how that may dictate morcellation, because it certainly responds well to these that I sense are a bit more of like the epithelial type prostates, but those fibrous prostates, it's really a nightmare sometimes, and it just is not as efficient. So, everyone has their Twitter picture. This was really tongue-in-cheek because I almost can't be on Twitter because of all the videos of people showing their perfectly clear urine after this operation. But in this particular case, we got lucky, and without traction, he looked okay. I think as I've reflected on learning this technique, what I find, and I think some of the folks here that are far more expert than me would probably agree, your enucleation time is going to be relatively static as you get really good at this operation. And so even for a large gland, you're probably going to be enucleating for somewhere between 45 and 75 minutes. Obviously, for these really small prostates, it's going to be quicker. But really where your time is going to be spent with these large prostates is going to be morcellation. So in this particular case, you can see the times there. The pathology was 168 grams, and it was benign. And my general schema is to keep folks, just because most travel from a long distance, overnight and have a voiding trial the next day. So with that, I'll turn it over to the next technique. And thanks again, John, for inviting me.
Casey, you don't go from the 12 o'clock above the adenoma, you don't enter the bladder anymore. How many people still do that technique where you enter the bladder? Some do. Okay, about half and half. Right. So we have a break now, 15 minutes. Is that okay, Mehdi? 15 minutes, and then we'll come back and we'll start with Joel giving us a talk. Okay, great.